Great. So thank you, Jerry, and thanks for setting that up. And I'm going to, as soon as the slides come up, I'm going to go through some data that really relies on three separate set of projects that we've been working on. The third one is around the dual population that was the impetus for a lot of this work that we've been doing with BPC and the National Academy. And that's the stuff that's sort of freshest off the press, meaning please don't quote the numbers, not because I don't want you to, it's just it might be wrong. We're still kind of verifying it. And so feel free to quote it at your own risk. Maybe that's what I should say. But what I'm going to try to do is use the much maligned claims data, which is still the best way to look at the picture of what is happening in our country, to talk about high-cost, high-need populations, really in three groups of folks. And we know why we do this, right? Because we know about concentration of spending. And so let me show you some data on these three populations. Let me tell you who they are, and then what the data look like kind of in a big picture way, and then I'll drill down. So, Jerry said this, some people look at top 1%, 5%, 10%. We're looking at the top 10%. And we're looking at three populations, three separate populations, somewhat separate populations. The first one is the non-Medicare population. So this is data from Massachusetts. Okay, so a little bit of a caveat. It's a one-state analysis. It's everybody who doesn't have Medicare. So they're not disabled, they're not 65 or older. The second group is people who have Medicare only. Okay. And then the third are folks who have both Medicare and Medicaid, who are the duals. And what we know is that the top 10% of spenders in the non-Medicare population spend about 2/3 of all the dollars of the non-Medicare spending. So that's how concentrated that group is. If you go to Medicare only, the concentration is a little bit less. The top 10% of Medicare only population represents about 58% of all the spending in the Medicare population. And then if you go to the duals, the top 10% represents about 42% of all the spending in that population. Okay? And then if you look at thresholds, so actually one kind of obvious point, but it's worth making, the sicker the underlying population, the less concentrated the spending. And that makes sense, right? Because if you look at the duals, for instance, the other 90% all have a lot of healthcare issues as well, and they're going to spend money. And so the sicker the overall population you're looking at, the less concentrated the spending is going to be. If you look at the threshold for becoming high cost, and again, back to those same three populations, so the threshold for becoming high cost is $11,000. Again, our high cost is defined as the top 10%. Another way to say it is 90% of people who don't have Medicare spend $11,000 or less in a given year. That number goes to 32,000 in the Medicare only population. Another way to say it is 90% of Medicare beneficiaries in a given year spend less than $32,000. And that number is much bigger for the duals. This is a population that's just expensive. This is a complicated population. It's a sick population with a lot of different healthcare needs. Okay, so next couple of slides are going to be things that we've already alluded to. Lots of people have sort of telegraphed, so I'm going to go through it very quickly, which is a big picture. Who are these patients? And again, this is going to be unsurprising data, but let me just go through it quickly. So again, in the non-Medicare population, basically, I'll just go through this quickly here. 2 points worth noting. It's people with who are high cost always have more chronic conditions. That's not a surprise. And then as you march across these three populations, you can see in general that the number of chronic conditions is rising. Another way of saying it is that the Medicare non-high cost patients in Medicare have even more chronic conditions than the high cost patients in the non-Medicare population. And again, this makes sense. Older, sicker population. Frailty indicators, this is coming from claims data. A bunch of people have done some work on trying to use claims data to try to come up with frailty indicators. It's basically trying to capture people's inability to do activities of daily living. And what you see is, again, and let me just show you the data and then I'll explain it. Again, 2 points on this. One is that if you have more of these, you're more likely to end up being high cost. But this really varies by population. So in the under 65, in the non-Medicare population, yes, there's a 5-fold difference between low-cost and high-cost patients, but the frailty indicators, the number of them are relatively small, meaning inability to do activities of daily living is not a major driver. In the Medicare-only population, this is a big deal. And interestingly, a bigger deal than it seems to be in the dual population, at least based on some preliminary data, and we're going to try to sort this out a little bit more. But it really, and again, when I show you the next set of data, this will make more sense. But what you see is in the Medicare-only population, people who have multiple frailty indicators, multiple inability to sort of do multiple activities of daily living, are the ones who tend to end up being much more in the high-cost population. And mental health diagnoses are also far more prevalent in the high-cost populations. Again, across all three populations we're looking at. Jerry alluded to this from his analysis, and we've seen this in a lot of other work. And I'm not going to say more about this now, but we'll come back to it. So the problem you've heard about over and over again is that none of these are monolithic groups, right? Not within Medicare, not within the commercially insured, not among the duals. And so I want to talk a little bit about our segmenting strategy that we began with our work for Commonwealth Fund, looking at the Medicare-only population. And then we have begun to apply it to the other two groups. And I think that requires further refinement. So I'll show you the data we have, but that work is ongoing. But let me take you through the approach that we use for defining and segmenting the Medicare-only population. We basically try to define subpopulations, these segments. We try to characterize their spending by type. And I'm going to just, again, in the interest of catching us up a little bit, let me go through our 6 segments. So the principles were they had to be mutually exclusive. You could not end up in more than one segment. We wanted to take the entire Medicare population and we wanted to bucket them into 6 groups. So they had to be mutually exclusive. We divided them in sort of a waterfall hierarchical fashion, and I'll explain what that means more in about 30 seconds as you see it. But we begin with one group, we take everybody out, then of everybody who's left, we take out the next segment, and that's how we kind of march people through it. And here are the segments. So the first group we began with, and by the way, this has been a very iterative, about a year-long process with lots of input from clinical leaders, working closely with Jerry's group. So this is not just something that our group sat down one day and said, how do we segment this population? I'm not going to claim that this is the perfect way to do it, but I think hopefully you'll agree this is one reasonable way to segment the population. And this is kind of where we've landed after a lot of thinking, a lot of iteration, and a lot of work. So first group again, we're now talking about the Medicare-only population. The first group we set aside was the under 65 disabled. Then we talked about the frail elderly. These are older Americans who have 2 or more frailty indicators. Then we talk about major complex chronic. So let me explain what this is. Chronic disease is one of those sort of waste bucket kind of things that there are lots and lots of things that make up chronic disease. Based on some work that folks at Yale have done and others, there appear to be about 9 chronic diseases that tend to be really much bigger deal in terms of spending, morbidity. And so our major complex chronic is the group that has 2 or more of those major chronic diseases, right? And if you think about it, heart failure is not the same thing as hyperlipidemia. They're both chronic diseases. They have very different implications for your health. They have very different implications for your spending. So major complex chronic is a group that basically has 2 or more of those major chronic diseases. Minor complexes has 1 or more with some minor diseases. Simple chronic, you might have hyperlipidemia. You're not completely free of chronic disease. And then the people who have none of these. And the one quick thing I will say is that there's lots of ways of sub-segmenting all of these. I'm not going to go through it because I've gotten the 2-minute marker. So let me tell you about what proportion of all high-cost patients look like within these buckets. And I'm going to go through all 3 populations kind of somewhat quickly. You can have a copy of the slides afterwards, but I want to make a couple of big picture points. If you look at under 65, so the non-Medicare, the commercially insured non-Medicare population, this is what the high-cost population looks like. Interestingly, it's not a lot of people with lots of major complex chronic. It's minor complex chronic and simple chronic. Okay, there's a little bit of a surprise to me, at least, that that's who the high-cost patients were in the commercially insured. Medicare looks very different. This is Medicare only, right? If you think about those 2 graphs, in some ways it'd be nice if I could have shown them next to each other. You'd see that these populations look very different. Under 65 disabled and frail elders are really your high-cost patients. And then among the duals, it looks different yet. And it's really again, it's under 65 disabled and frail, but now the dominant group seems to be the under 65 disabled. And it's another way of saying that even within these three populations, the high-cost patients look very different from each other. Okay, I want to just show you one more set of data, and then I'm going to wrap up. And this, I think, kind of starts getting at the kinds of insights you can have. And let me walk you through what we have here. So this is now the Medicare-only population. And I want to show you what spending looks like within the segments. So the first group I'm going to go through is the under 65 disabled. Then I'll go through frail, and then I'll stop because I could spend too much time on this slide. So under 65 disabled spend on average about $16,000 a year. This is among high-cost patients on inpatient care. Another 13 on outpatient care. Their post-acute care and long-term care is about $6,000. But the big bucket for this group is Part D spending or drug spending. And then a little bit of everything else, right? But the big spend under 65 disabled is Part D. Among frail elderly, it actually looks pretty different. It's $24,000 in inpatient spending, $6,000 in outpatient, and $24,000 in post-acute care and long-term care. So the two big buckets in frail elderly are inpatient spending and post-acute care, with Part D actually making up a really small proportion. And and then in the again, I'm not going to go through all of the rest, but what you see once we get into the chronic disease groups is that it looks, again, pretty different. And the point on this set of slides is that depending on the population, the spending looks very, very different. And so to think about post-acute care as the big cause of spending, or the inpatient care as the big cause of spending, I think misses the subtlety of what you need to actually be looking at when you target these populations. And just going through under 65 disabled versus frail hopefully gives you a flavor for how different these populations are and how you want to think about your approach to spending very differently. Last slide on data. Preventable spending, again, this is Medicare only. We looked at, there are lots of ways of defining preventable. We looked at ambulatory care spending, ambulatory care sensitive condition, and I just want to show you one set of data here. Let me just go through this quickly. The big point on this is if you want to think about ambulatory care sensitive conditions, most of that spending is among frail elderly. Right? They make up 10% of the total Medicare population and 45% of all the ambulatory care sensitive condition hospitalizations. Obviously not the only way to define preventability, but that is one. Under 65 disabled is another group that has a lot of ambulatory care sensitive condition spending. And so all of this is to say if you're a clinical organization or if you're a policy person and you're trying to think about how do we reduce preventable hospitalizations, targeting everybody doesn't make a whole lot of sense. Targeting a couple of populations is probably going to be much more useful. Okay, key takeaways from all of this work. So the key takeaways are the three populations are all quite different. The sicker the population, the less concentrated the spending, and the sicker the population, the higher the threshold for being high cost. I think all of that should make sense. I think it's important to think about the fact that it is possible to segment patients in each population, and the segments really are very different subpopulations. And I'm going to just get all of this on the board. So if populations and subpopulations are different, then the point is strategies for improving care are going to be different. Strategies for lowering costs are going to be different. And it also begins to, I think, pose some very interesting questions. I ran into Jeff yesterday at the airport last night, and we were talking about this. We were talking about organizations that are, for instance, really terrific at taking care of frail elderly. And we wondered out loud, are they going to be the same ones that are going to be really terrific at taking care of people with chronic disease, who are not frail, who are not elderly, who don't have a lot of the same social needs, but have very complex medical needs? The answer is maybe, but it's entirely possible the answer is no. And so I think we have to think about, are we trying to find one right way of delivering care to this very complex population, or do we really need to think about how different organizations play to different strengths and different approaches? There's lots left to do. We have other populations that we're going to work on trying to understand kids. We've brought this up multiple times today. We're also doing a lot of work trying to understand provider characteristics. All of this seems to assume somehow that this stuff is fixed. You can imagine frail elderly costs vary dramatically based on which provider organization they get their care in. One of the key questions is, why do some frail elders end up being very high cost while others who look exactly the same end up not being high cost? and what differentiates them, and what can we do. And then issues around persistence and transience, you heard some of this earlier from Denver Health folks, are really important. Why do some people become high cost and stay high cost? Other people become high cost and then drop to being low cost, and what's different about them. So a lot of work ahead. I'm sorry I ran through a lot of information in 10 minutes, but it's just one way to frame, I think, the value of segmentation and the kinds of insights, even with claims data, that you can begin to get about how to take care of these people. Okay. Thank you. Paul.